And what the size of the stimulus? The size 3 or size 5. And this is what we feed to the computer. This reliability data. Reliability data is nothing but the fixation losses, false positives and false negatives. Normally, what is the normal range? The normal range depends on the stage of glaucoma, what we are dealing. I will tell. There is nothing like normal range. Then comes the raw data. The most important thing is the raw data. The raw data is the retinal sensitivity at each selected point. And these are the normal retinal sensitivity values in dBs. Better number is a good retinal sensitivity. The lower number is bad retinal sensitivity. 0 indicates, that means that spot is not responding to the maximum intensity of light projected by the perimeter. That is almost like absolute scotoma. And these are the points innermost circle in 24-2 and 30-2. We don't test up to fixation. This is the 3-degree circle. In 10-2, almost we test up to fixation. So never comment any foveal split from 10-2, from 24-2 and 30-2. If you see any sign in front of a number, that means the maximum intensity of light is not 10,000 and it is somewhere 9,000 and it requires recalibration of the machine or bulb should be changed. Now this raw data becomes the basis for the formation of the grayscale and the total deviation numerical plot. Grayscale is very, very important. From the grayscale you can know many things. You can appreciate the pattern of the field effect very well. And the most important thing from the grayscale, you can assess the pattern and the progression in the overview printout. And the better retinal sensitivity is given a better shade, and as the retinal sensitivity decreases, the black shade is given. Then comes the total deviation numerical plot. The total deviation numerical plot is nothing but the raw data expressed in deviation from normal values. The normative data for at each point, the normative data is stored in the field analyzer. This raw data is compared with the normative data and expressed as the deviation from normal values. So the total deviation numerical plot is nothing but raw data expressed in deviation from normal values. And if you see a minus, that means the loss of retinal sensitivity indicates. If there is no sign, it is better than normal. 0 means there is no deviation from normal. And we are always concerned with the digits in front of a minus sign in front of it. What is the loss? Higher the number, higher the loss. Lower the number, lower the loss. So 0 indicates no loss of retinal sensitivity. And the plus indicates better than normal. And minus is the loss of retinal sensitivity. For all practical purposes, the total deviation numerical plot can be called as loss of retinal sensitivity plot. See, this total deviation numerical plot will now become the base for the probability plots, the base for the mean deviation index, and the base for the pattern deviation, pattern standard deviation. The probability plots, the probability plot, the total these numbers are actually according to the p-value, they are converted into the probability plots. Forget about what is the p-value and all. Usually if the loss is more than 1 or 2, this symbol is given, and any deviation more than 8 dB, the loss of retinal sensitivity more than 8 dB, black square is given. So a black square in the probability plot indicates the loss of retinal sensitivity is more than 8 dB. A black square in the probability plot does not mean that it is absolute scotoma. It only tells that the loss of retinal sensitivity is more than 10 dB. And even if you see black squares in 24-2 and 30-2 around fixation, don't comment that there is a foveal split. It only indicates that these are the points on 3D degree circle. So don't comment a foveal split from 24-2 and 30-2. And the only black square indicates the loss of retinal sensitivity at each point is more than 10 dB. So never assess the depth of the field effect from the probability plots. Probability plots are created only to know the extent and the pattern of the field effect. So the scotomas can be a localized scotomas or generalized scotoma. When there is a localized scotoma, the pattern and the extent of the field effect can be known in the total deviation probability plot. The total deviation probability plot and the pattern deviation and total deviation probability plot, they look similar. The total deviation probability plot is showing generalized depression. It indicates usually a cataract also can have this. Now if this patient develops a neurological condition, a black square is always, even if it is increased by another 5 dB or 6 dB, the black square will not change. So in order to appreciate a localized scotoma in the generalized depression, the probability plots are created. Now we can appreciate the localized scotoma in a generalized depression, and you can appreciate in the grayscale. So pattern deviation probability plots are created only to know the localized scotomas in the pattern in the generalized depression. It is actually mean deviation index and pattern standard deviation. Mean deviation index, it is nothing but the average of all the numerical values of total deviation numerical plot. The most important concept of mean deviation index. The mean deviation index in a localized scotoma, the mean deviation index in generalized depression. Take for example in this case, the mean deviation index is 6 dB, around 6 to 7 dB. But it is a localized scotoma. The loss is only confined to this area, where other points the retinal sensitivity is normal. But this loss is distributed among all the points and expressed as a mean deviation index. So a mean deviation index in a localized scotoma is not the true index of loss of retinal sensitivity. And this is a very, very important concept. When we consider actually the progression analysis in a localized scotoma, even though there is a change of mean deviation by 1 dB, suppose a localized scotoma confined to 1/4 quadrant, and the change in mean deviation is 2 dB. That means it is equivalent to 8 dB. So any change in mean deviation, even by 2 dB, in a localized scotoma, the progression is considerable. So a mean deviation in a localized scotoma and the mean deviation in the PSD. PSD is actually the sign to pick up early localized scotoma. It is the sign to represent early localized scotoma, any irregularity among the points. So it is an early sign to pick up glaucoma, the PSD is developing. And the glaucoma hemifield test is also nothing but it is a refined PSD. The change in retinal sensitivity on either side compared, and we know in glaucoma, the retinal sensitivity on either side of horizontal axis, they differ. And on that basis, the glaucoma hemifield test is developed. So only glaucoma hemifield test positive means it only indicates that the retinal sensitivity on either side of horizontal axis, they differ. So a 0 in raw data is absolute scotoma. A 0 in total deviation numerical plot, it indicates there is no change in the retinal sensitivity, it is a normal retinal sensitivity. A 0 in total deviation probability plot, because the conversion, it is the 7th best point, it corresponds to the 7th best point of total deviation numerical plot. Now, coming to the interpretation of visual fields. Actually, interpretation of visual fields is nothing but the interpretation of probability plots. Always when you see a scotoma in the probability plot, the most important thing is identification of the artifact. You should know that the small people, refractory error correction not properly given, fixation losses, false positives, false negatives, dim artifacts. So all these can produce refract the artifacts. So you must develop an art to identify the artifacts. And you should know, to pick up early localized scotoma, there is an Anderson criteria. And Anderson's criteria is to pick up early localized scotoma. You know that to pick up early localized scotomas, two indices are developed. One is PSD, one is glaucoma hemifilter, GHT. And there should be minimum 3 points in the probability plots, the cluster points, and non-it scotomas. And if there, and these points, 3 points, need not have the p-value less than 0.5%. Even the p-value 2 points have less than 5% and 1 point with 1%, then we say that the Anderson's criteria is positive. So now interpretation of the visual fields. In a suspicious case, early case of glaucoma, established case of glaucoma, advanced case of glaucoma, glaucoma associated with cataract, and assessment of glaucoma progression. I will show you the approach of two ophthalmologists in a suspected case of glaucoma. This patient came to me already diagnosed as glaucoma with treatment for second opinion, and the only thing is there is a disparity, and he is carrying the visual fields, and OCT is one area is showing a dip in the red zone, and a localized scotoma fulfilling Anderson's criteria, and reasonably good, well done test, started the treatment. I told you what is the normal range of reliability data. There is nothing like normal range. When you are suspecting the patient, the most important thing is all the tests should be 100% perfect. The fixation losses, false positives, false negatives should be 100% perfect, and you have to always select Theta standard. And in this group, age of the patient is very, very important. When you are suspecting glaucoma, you have to enter the age correctly. Suppose in an advanced case of glaucomas, the age can be relaxed on either side 4 or 5 years, no problem. But in a suspected case, everything should be meticulous, because the normative data of that age group will be compared. So age, you should take all the precautions. And when I repeated the test, you see, the false positives, false negatives, they came all 0, 0, 0. And there is no scotoma. See? So, in early case, this is the approach. I will show you the ophthalmologist, another ophthalmologist approach. He suspected glaucoma. He is a very senior army officer in Pakistan, seen by an ophthalmologist. Actually this is showing a generalized depression, because pattern deviation probability is normal. Generalized depression almost, but okay. And the ophthalmologist started the treatment. But when this army man went to another ophthalmologist, he studied the fundus very carefully. He labeled, difficult to label as glaucoma. He sent to me by mail what is the opinion, Dr. Reddy, in this case. Then we kept the patient under observation. So, see the approach. When you suspect, evaluate the fundus very meticulously, interpret the visual field with perfection, Theta standard, reliability 100% perfect, repeat the fields till you get satisfied, get fields. Don't hesitate to take second opinion, interpret visual fields, OCT with care, take enough time to start the treatment. So next comes now suspected, now a very early case. You are seeing the case of glaucoma. I tell you the importance of the point patterns. Usually we say early cases you select 24-2 or 30-2, advanced cases 10-2. But in all the cases it is not like that. This case, first time coming, borderline, almost borderline tensions, first time coming and we saw the field defect. This is the field defect only appreciated, and this is the field defect appreciated. 24-2, as usual the fields were taken with a mean deviation of -7. This, but if you carefully examine the fundus, almost this is approaching towards the fovea. Almost this is approaching towards the fovea. When the 10-2 was taken, see almost the left eye is almost started here with a mean deviation of 18. So it is very unusual. Almost the patient is becoming blind. Whereas in 24-2, it is not looking like advanced. So you can't grade glaucoma just on the basis of mean deviation. So in an early case, I will tell you the early case of glaucomas. Two cases, the approach will be different. Both are early. Nerfibular defect is appreciated, and you see the scotoma here. Scotoma. The most important thing when you see, even it is a relative scotoma. It is a relative scotoma. Retinal sensitivity is not grossly decreased, -3, -4, -6. Still it produced nerfibular defect. So most important thing that nerfibular defect does not indicate that it is a complete loss of retinal sensitivity. Even a relative scotoma can produce nerfibular defect. Here both are early cases, but if you observe carefully, one case it is almost coming towards the center. The progression is towards the fixation. Where is the progression is not towards the, you see retinal sensitivity is good 5 and 3. Here retinal sensitivity is 15 and 12 minus. The loss is -15, -12. Where this loss is -5 and -3. So even the both are early, the treatment here you should be very aggressive, and here you can be relaxed. So the role of visual fields is not only for diagnosis. The role of visual fields is to tell the prognosis, to set the target IOP, and to set the drug selection. Now you take for example in established case. In established case we know there is no role of PSD and GHT. And the most important thing, the extent of the field defect, the progress and towards the fixation, and what is the foveal status. You have to concentrate on the probability plots, raw data, total deviation numerical plot for the depth. You see, here I am showing two cases of established case of glaucoma. Both are presenting with localized scotomas, is a biarcade scotoma. The first case, it is a relative scotoma, probability plot, and a relative scotoma, and the foveal, these points, the loss of retention around the fixation is not bad. And when you compare the next case, this is absolute scotoma. Almost the point on the 3-degree circle showed the loss. So even though both are early established glaucomas, almost looking like same size of scotoma, but the treatment differs. One is becoming absolute scotoma, one is involving the central fixation, another is relative scotoma not involving the fixation. So, in established case of glaucoma also, the visual fields will help you to set the target IOP and tell to the patient about the prognosis. In advanced case of glaucomas, usually when with 9 cup and all, usually we select 10-2. 10-2 is the circle, the points. Here almost we are testing up to fixation. Here the distance between point to point is 2 degrees and from the axis is 1 degree. The interpretation of 10-2 fields, you always concentrate on the raw data. You concentrate on the raw data. Don't bother about anything. Because in advanced case of glaucomas, our main aim is to know how much field is retained. So concentrate on the raw data. Don't bother about what is the mean deviation, what is the PSD, and you can next comes the patient suspected case of glaucoma with cataract. Suppose we see cataract and you suspected glaucoma. You know that cataract will have a generalized depression, uniform generalized depression, and the probability plot does not show any scotoma. That means uniform generalized depression. The definition of uniform generalized depression by statistics, the total deviation probability plot showing generalized depression with a normal pattern deviation probability plot. And if this patient is having irregular generalized depression, that means a localized scotoma under the generalized depression, that means it is indicator of some neurological sign. It may be glaucoma or it may be due to any CNS involvement. In this case, the patient's cataract, suspected glaucoma, visual fields were taken. There are no scotoma in the pattern deviation plot. Therefore, there is no evidence of glaucoma. Now, in this patient, suspected glaucoma because of the field defect, nerve fibrillary depreciated, and so we could see a localized scotoma in the generalized depression. So the glaucoma is suspected. In this case also, the most important thing is the treatment point of view. If this is a deep scotoma, we have to go for combined. Suppose if it is very early scotoma, you need not go for combined. Only because you can have a clear corneal cataract extraction and preserve the conjunctiva for future trabeculectomy. So in this case, actually the retinal sensitivity is not that bad. So coming to the overview printout, the progression analysis. I always concentrate on the progression, only the overview printout. Don't bother about GPA and all. You concentrate on the overview printout. What is the previous? The progression means change in mean deviation. There is a change in mean deviation. If the change in mean deviation, we have to assess whether the change in mean deviation is real or not. If there is a change in mean deviation uniform, maybe due to cataract, that means the change in mean deviation is uniform. That means PSD will be changed. A change in mean deviation with change in PSD indicates irregular progression. A change in mean deviation with normal PSD, with no significant change in PSD, indicates uniform progression. And when you assess the mean deviation, you always see how the previous test was done. What are the false positives, what are the false negatives, how are the fixation losses, what is the size of the people, what strategy used. So you have to come to a conclusion. What is the mean deviation of the previous test and what is the mean deviation of this test, what are the parameters. So a change in mean deviation, then you have to consider there is a real change in mean deviation. Then that mean deviation, whether it is due to progression due to glaucoma or usually due to some other factor like cataract. When in 2003, you see there is no change in the probability plots. But if you see the grayscale, you can appreciate the progression, and the progression is appreciated from 7 to 12. So a change in mean deviation in localized scotoma, 7 to 12 means it's a 5 dB, but if you see almost the retinal sensitivity, almost good retinal sensitivity here became almost absolute scotoma. So a change in mean deviation, even though it is 5 dB in a localized scotoma, it indicates that it is very huge. So the concept of mean deviation in a localized scotoma, the concept of mean deviation in a generalized depression, a minute change of mean deviation in a localized scotoma, you must be very careful. In this patient, there is no change in the mean deviation from almost 2000, for 4 years it is seen. You see there is no change in the mean deviation. But if you see carefully, the retinal sensitivity is present only in 4 or 5 spots, and all the points the retinal sensitivity is 0. Even the change in 4 points will be distributed to all the points. So even a huge change in these 4 points will not be appreciated in the mean deviation. So in this test, actually you should go for 10-2 to appreciate the progression. So all these things you have to take into criteria. How many points? When you are assessing progression analysis, you always concentrate. When you are considering the mean deviation, you concentrate on how many points are having retinal sensitivity. Because those points only progress. Those who are already absolute scotoma, they don't progress. So the points retinal sensitivity having the retinal sensitivity, that is distributed to all the points. So change in mean deviation, you must be very, very careful when you are considering progression. See, here only all the points are having 0 zeros. Even in 10-2. Even 10-2, all the points are. So the only retinal sensitivity is confined to these 10 points or 15 points. A change in these points will, if you want to express in mean deviation, it will be all the points, it will be distributed to all the points and expressed as the average. So in this situation, you only see point to point. Previous 3 to 3, there is no progression. 0, 12 is converted to 0. Here 19 is 10, 20 is certain. So this area is progressing. So always concentrate point to point. I will show you another case, very interesting case. The patient followed for 4 years. Even the first visit, he suspected glaucoma on this part and nerve-fibrillary defect. This the field was taken. This is the right eye and this two left eye. You see, this is the field, and the mean deviation is 5, and the mean deviation is 7. In the first visit, only 24-2 is taken. This is the 10-2. And this is the 24-2. In 24-2, the mean deviation, there is no change. Actually, this mean deviation is 5. With false negative 7. When the false negatives become 1, the mean deviation actually became good. So almost there is no progression in the 24-2. But if you see 10-2 in this patient, the mean deviation 7 became minus almost 10. 8 became almost 10. There is a change in 2 dB. In a localized scotoma, 2 dB means it is huge. And if you see the progression, it is almost coming into the fixation. So actually the progression is occurring in the 10-2 area. And if you see only 24-2, there is no progression. So most important thing is the fundus examination. So if you go and going on concentrating on the fundus examination, you can find the cases like this. Even in left eye, the left eye is not showing progression in 24-2, but here the left eye is started showing in 2012. Almost this is the scotoma in 10-2, but they are increasing. See, this case actually the glaucoma process, glaucomatous process actually starting in the central area 10-2 in the macular-papillary bundle area. So most important thing is for even the progression analysis, you have to concentrate on the where the point patterns you have to select and done. Thank you. If you have any doubts, you please let me know.